and I will be presenting about how oral glucose stimulated C-peptide assay can augment the specificity of LADA clinical risk score in a non-obese Indian cohort. So as you all know, LADA is latent autoimmune diabetes of adults. It's called 1.5 diabetes because it blends features of type 1 diabetes because of the autoimmunity, and feature of type 2 diabetes because it presents in adulthood. And this has a very high prevalence in southern states of India, as high as 30%. Now the diagnostic gap is that an adult presenting with hyperglycemia, anytime they present, especially in a remote part of the country, they are invariably diagnosed as type 2 diabetes mellitus and they are started on OHAs. So if this patient turns out to be a LADA patient, now this OHA, especially sulfonylureas, they can exacerbate the autoimmune process, and valuable time where the patient could actually be treated with insulin, which can preserve the beta cell reserve in these patients, are lost. Only when there is non-responsiveness to the OHAs are potential causes of not responding to this or LADA is looked at. So why there is this delay in diagnosis is mostly because of the confirmatory test, which is the autoantibodies, which are very high cost and not accessible to all parts of India. It costs around 3,500 to 7,000 rupees across different labs in India. And the other option would be to look at the clinical risk scores, which can identify the potential LADA cases, but what they have in sensitivity, they lack in specificity. So the other markers would be C-peptide and insulin, and C-peptide is preferred over insulin because it has a longer half-life, it is not affected by these anti-insulin antibodies. And stimulated C-peptide would show the beta cell reserve, but the methods of stimulation that are already known or being done, which is the mixed meal tolerance test, requires sampling across 5 times, or the glucagon stimulation test requires injection, none of which patients are really okay with. So we proposed a study where you do a simple stimulation method, just give oral glucose and see the stimulated C-peptide levels and whether this can be used, this has any diagnostic potential or not. So we designed a cross-sectional study, and around 500 potential LADA cases who fulfilled the Ferlano's LADA clinical risk score, which had 5 criteria, and if at least 2 of these were fulfilled, they were included in the study. And obviously any known cases of diabetes, type 1, type 2 or any other metabolic disorders, they were excluded from the study. And next came they were compared with healthy controls, because this was a standardization of this newly designed assay. So any non-autoimmune history or diabetes, they were excluded from the study, and normoglycemia was determined on the basis of ADA criteria. So fasting samples were taken in these patients. They were given 5 gram of anhydrous glucose dissolved in 100 ml of water, and then 1 hour later the stimulated samples were taken and assessed by chemiluminescent immunoassay. So obviously the potential LADA cases had significantly higher fasting and stimulated plasma glucose levels as expected. Their BMI levels were also, there was matching, no significant difference. But if you see here, the fasting C-peptide levels are significantly higher in the potential LADA cases, around 0.59 nanomoles per liter. But their stimulated serum C-peptide levels were significantly lower, 1.21 nanomoles per liter. The values are also given in nanograms per milliliter. That is how most of you might have seen the results. So if you look at the graph here, what we have here is the blue color indicates the cases. So they start with a higher fasting C-peptide level, and upon stimulation it actually becomes lower. Now when you do the comparison, 1.21 and 1.31, the difference is only marginally different. So we looked at the ROC curve analysis, and at a cutoff of 1 nanomole per liter, this showed high specificity of 85%. For fasting serum C-peptide, the cutoff of more than 0.58 nanomoles per liter. Now all of these assays were better in specificity, but their sensitivity was very low. So we also did the multivariable regression analysis by the bidirectional stepwise method, and both fasting serum C-peptide and the stimulated serum C-peptide showed to be very good predictors for potential LADA cases, with fasting C-peptide showing the odds ratio of 1.63. So coming to the discussion, when we look at the C-peptide levels, there is a consensus statement given by the American Diabetes Association and the European Association for Study of Diabetes, that at a cutoff of 0.6 nanomole per liter, if it is more than that, you can confirm as type 2 diabetes mellitus. Now this cutoff cannot be applied to the Indian population according to the results of our study, because at more than 0.58, which is just very tiny difference, are the LADA cases according to the results of our study. So if you see, the blending of the features still shows with C-peptide that higher fasting C-peptide levels is seen in potential LADA cases, just like type 2 diabetes mellitus, but the stimulated C-peptide levels, which is lower stimulated C-peptide levels, is also shown just like type 1 diabetes mellitus in this potential LADA cases. And several studies which are in agreement are also shown here, where type 1 diabetes mellitus at different cutoffs, there is no uniformity there. They have used different methods. I have taken the mixed meal tolerance test here. They have using this, they have arrived at the stimulated C-peptide levels, whereas for fasting levels are utilized for type 2 diabetes mellitus. Now the study has the significant limitations. One is we did not do the autoantibody assay, which is the GAD65 assay, because of budget constraints, and we did not do a direct comparison with type 2 diabetes mellitus. This is the first time we were standardizing such an assay, and also only a cross-sectional design done at a single center. So we propose for the future that longitudinal studies be done where LADA cases are confirmed by the autoantibodies, and comparison is done with type 2 diabetes in different centers involving diverse population. Actually, we have already made the proposal and submitted to ICMR. So our recommendation is that an adult presenting with hyperglycemia, if they have the clinical features, then they be assessed for stimulated C-peptide assay, so that there is better documentation, better evidence-based medicine there. So these are my references. We acknowledge ICMR for the funding of the project. Thank you all very much.